All right, let's talk about one of the most common arrhythmias you're definitely going to see out there in the clinic, atrial fibrillation, or as we all call it, AFib.
So let's kick things off with a classic scenario. Imagine a 72-year-old patient comes in telling you they feel a weird fluttering in their chest and they're just tired all the time. You go to check their pulse and it's not steady. It's fast and all over the place, what we call irregularly irregular. What's jumping to the top of your list? You got it. That whole picture just screams atrial fibrillation. So let's dive into what's actually happening here.
But before we can really understand the chaos of AFib, we've got to take a quick look at what a normal, healthy heartbeat is supposed to look like. Okay, so in a healthy heart, everything runs like a well-oiled machine. It all starts with the sinoatrial node, or the SA node. Just think of this as the heart's own natural pacemaker. It's sitting up there in the right atrium, and its job is to send out a steady, organized electrical signal. That signal then spreads across the heart's top chambers, the atria, and tells them to squeeze in this beautiful, coordinated way. That's our normal sinus rhythm.
So that's the ideal. Now let's see how that perfectly organized system gets completely thrown into chaos during atrial fibrillation.
So what is AFib, really? Well, in simple terms, it's total electrical chaos in the atria. Instead of that one clean signal coming from the SA node, you've got hundreds of random signals firing off. And with all that noise, the atria can't possibly contract properly. They just end up sort of quivering.
Let's put these side by side because it really makes the difference pop. A normal rhythm, it's regular. AFib, it's the classic irregularly irregular. Normal atrial contraction is coordinated. In AFib, it's just that chaotic quiver. And this has a huge downstream effect, right? The ventricles try to keep up with all that noise, driving their rate way up from a normal 60 to 100 beats per minute to a really fast 120, sometimes even 160.
So, how does a mess like this even get started? Well, the most common theory involves what we call ectopic foci. Think of these as tiny little troublemaker cells, usually hiding out in the pulmonary veins, that just start firing off their own electrical signals like crazy. They're firing so fast and so furiously that they completely overpower the heart's real pacemaker, the SA node. And the result of that takeover? The atria get bombarded with all these chaotic signals and just give up trying to beat properly. They just start to quiver.
And here's the really tricky part. This isn't just an electrical issue. Over time, that constant chaotic firing actually starts to damage the heart tissue itself. It can cause scarring or fibrosis in the atria. We call this atrial remodeling, and it creates this awful vicious cycle. The more scarred the tissue gets, the easier it is for these chaotic signals to take hold, which makes the AFib more likely to stick around for good.
Okay, so we've covered the how. Now let's connect all this science back to the patient. What does this actually feel like, and what are the really big risks we need to worry about?
So, when a patient's heart is beating that fast and that inefficiently, they're going to feel it. They often report palpitations, that thumping or fluttering sensation. And because you lose that coordinated atrial squeeze, often called the atrial kick, less blood gets pumped with each beat. That's why fatigue and shortness of breath are so common. But here's something that's so important to remember. Some patients feel absolutely nothing. Their AFib is found completely by accident.
But as uncomfortable as those symptoms are, they're not what keeps us up at night. The single biggest, most dangerous complication of AFib is this: a 5 times increased risk of stroke. This is, without a doubt, the main reason we treat AFib so aggressively.
Okay, so why the huge stroke risk? It all goes back to those quivering atria. When they aren't squeezing properly, blood doesn't move through like it should. It starts to pool and become stagnant, kind of like a murky pond. This happens most often in this tiny little pouch called the left atrial appendage. And what happens when blood just sits around? It forms clots. And if a piece of that clot breaks off, it can take a direct flight right up to the brain, get stuck, and cause a massive stroke.
So, with that terrifying risk on the table, what's our game plan? How do we manage this? It's all about getting back some control, and of course, preventing that disaster.
Our management strategy really stands on 3 main pillars. Number 1, and this is the most important, is stroke prevention. We have to stop those clots. Number 2 is rate control. We need to slow that heart rate down to help with symptoms and prevent the heart from wearing itself out. And number 3 is rhythm control, where, in the right patient, we try to get the heart back into its normal rhythm.
Now for stroke prevention, blood thinners or anticoagulants are our go-to. The old school option is warfarin, which works well, but you have to get your blood checked constantly. The newer kids on the block are the DOACs, or direct oral anticoagulants. These are great because they don't need all that monitoring. And here's the key part. They generally have a lower risk of causing bleeding in the brain, which is a huge win.
For those other two pillars, we have different tools. For rate control, the goal is just to slow things down. Think of it as telling the ventricles to ignore all the chaos upstairs. We use drugs like beta blockers for that. For rhythm control, we're actually trying to fix the underlying problem. We can try shocking the heart back into rhythm, that's cardioversion, or use special drugs. We can even do a procedure called an ablation, where we go in and zap those troublemaker cells causing all the problems.
Okay, I know that was a ton of information, so let's boil it all down. If you're studying for an exam, this is the slide you really want to pay attention to.
All right, here are your must-knows. The hallmark of AFib on an exam? That irregularly irregular rhythm. What's causing it? Those ectopic foci, usually from the pulmonary veins. What's the biggest risk? And I can't say this enough. The biggest risk is that 5-fold increase in stroke because of clots in the left atrial appendage. And how do we manage it? It's all about our 3 pillars: rate control, rhythm control, and absolutely critical, anticoagulation.
So if you take away just one thing from all of this, let it be this. At the end of the day, managing AFib is all about taming that chaotic rhythm to prevent its absolute worst consequence, a stroke.